Let's review the anatomy of the thoracic cavity and how it develops. Remember, there are 5 phases of fetal lung development. The first one being the embryonic phase, where it just starts out as a couple of buds, and then the pseudoglandular phase, and then the canalicular phase. I remember this one because I think of canals as vessels ride through canals, and this is when there's a bigger development of your blood vessels. And then next is the saccular phase, which is actually about when the baby is born or comes to term. And then finally is the alveolar phase. Remember, alveoli stop proliferating or growing when body growth stops. This means they don't stop until adulthood. A large portion of the lung proliferation occurs in the first 3 years of life. Alveolar sacs in a newborn are structurally different than adult alveoli. Alveoli in newborns also do not have pores of cone. These are small openings which are thought to exist between adjacent alveoli. Infants and children also have a lower functional residual capacity. That's the amount of air remaining in the lungs after normal expiration. Infants and children have larger hearts in proportion to the thoracic diameter, which decreases their lung capacity. And then infants have more compliant chest walls because their ribs are more cartilage at the point of birth and their first years of life. Elastic recoil of a child's lungs is less than half of an adult. Children have proportionally larger abdomens, which push up against the diaphragm. The basal oxygen consumption is twice that of adults, 6 milliliters of oxygen per kilogram for children versus 3 milliliters of oxygen per kilogram for adults. Children also have a lower pulmonary reserve and increased oxygen consumption. Children will desaturate more rapidly than adults. They also will recover more rapidly than adults. But these are just a few of the reasons why children are at a high risk for respiratory distress as soon as they have any type of airway obstruction.